So I'm going to talk a little bit about adolescence and autism spectrum disorders, and I'm also throwing in DSM as a freebie. Which is, it is what it is, and as you know, I'm from Yale, so there's the bulldog. And you know, people have conflicts of interest. I have various books, as you heard about. The one that we were plugging is the cheap one. And the reason we did a cheap one, I have a course I've taught for close to 30 years for Yale College. And actually, if you go online, you can watch the lectures. It's on YouTube. Type in YouTube and Yale and autism, and up pops this course. And we've been doing this course for Yale College students who actually spend 3 or 4 hours a week working in schools for kids on the autism spectrum, and they come in and have a seminar. And so the lectures are the filmed part of the seminar. And we did this book thinking we wanted to have a good resource for parents that was a quality resource. The problem when you go on the internet, if you've never gone on the internet, type it tonight into Google or YouTube, type Google and autism and see what happens. You will get 25 million hits. The trouble is a lot of those are just total crap. And so we wanted to have something that we thought was a quality resource, and so that's why we did this book. And it's really quite affordable. So like the former vice president, I have absolutely no conflicts of interest. So I have a number of different perspectives I want to enclose. One, I've been teaching this college class for over 25 years. I've been a clinician for 30 years at Yale. I've been an advocate for students on the autism spectrum. I'm a member of the Yale College Admissions Committee one day a year, which is a very humbling experience. You'll never get into Yale. That's the bottom line. They zoom through kids with perfect SATs. Nothing special. You think I'm making this up? And I'm not. And it's a very, but anyway, it's a whole other experience. And of life, I'm also a consultant to the same. So increasingly, and we'll talk about this, I get requests from the admissions committee. This student has identified himself as having Asperger's or autism. Would you take a look at his file? And I do, and I tell them what I think. And sometimes they say, yes, this is a potential admit, and sometimes they say, not in 1,000 million years. That's a different story. The siblings, I'm just setting up to do my class for the spring semester. I met with my teaching fellow. The one thing that happens, siblings get preference for my course. Otherwise, it's all seniors. If you say you're a sibling, you're in home free. That's another story. So I'll tell you about it. There's a whole other story which is about Native Americans. You wouldn't even believe the interesting troubles that Native Americans have in this sad university. And a parent of a student who went to Yale, which I've got to tell you is a fascinating experience. Yale's a very nice place in many ways. It has a highly evolved residential college system. And we're talking state of the art. And I got to say, I've got nothing bad to say about Yale, having shelled out a lot of money. And this kid developed, we thought she was going to be a Latin major. Go figure, right? She took a seminar on Tibetan Buddhism, and the next thing you know, it's Tibet. And so she took Sanskrit, her first college language, well-known language. Jesus, I'm saying to my wife, we're paying this out money and the kid's taking Sanskrit. And you can't make this stuff up. And then, of course, the kid wants to take Tibetan. So they have 3 kids at Yale who are taking Tibetan. They bring in a teacher who has a beginning, an intermediate, and an advanced class. So that's the scoop. That's the good news. And it's actually for Yale College, it's wonderful. And every year, every college, and there we have 10 or 12 colleges, has 1 or 2 students on the autism spectrum. They sometimes identify ahead of time, and sometimes they don't, which is fascinating. And don't ask me to count the number of winners of the National Spelling Bee that I know. Because it's a lot. Some paradoxes. So autism was once thought to be rather rare. Now it's thought to be very common. It was confused with childhood schizophrenia. We now know it's totally separate. It was thought to be congenital, but usually it's not diagnosed until 3, 4, or 5, which is actually bad. The earlier we diagnose, the better kids have in terms of outcome. Because, and I'll show you why in a second, we think that the more we can get in there and intervene, the better kids do, which is a good news story, actually. And there are diagnostic tensions we'll come back to way at the end with DSM. Lumping, splitting, one or many. This is a back and forth, and it goes over time, back and forth. And it's an interesting discussion. And categorical, meaning you have it or don't have it, or how much do you have? Dimensional, like blood pressure. And again, there's these things you think they're different. They're actually rather similar in some ways. It's just how you cut the pie. So changes over the last 3 decades. The good news, and one of my other hats I showed you in that first slide, is I edited a journal, the Journal of Autism, which is the oldest in the field. Back in 1993, which was the year before DSM-IV came out, we had about 350 papers. Last year we had 2,400 peer-reviewed scientific papers. Not chapters, not books, things that went through the peer review process. So it's exploded. We have every year for the last 7 or 8 years that I've edited the journal, we've had a 10% increase in papers. We have not increased our page limits, so we have a problem. And that's, yeah, there it is. It's literally right there. That's actually a good problem to have, but it's a new thing in the field, and it's wonderful. Increasingly, we have better outcomes. Earlier diagnosis leads to better and more effective intervention, and we also see more diagnostic changes. There are many challenges for research. I don't want to dwell on this too much. The process of grant review is not perfect. In fact, there are more and more troubles getting grants funded, but for this purpose, you should realize that the real problem at the federal level, as far as I'm aware, I may be wrong, there's not a single federal grant on adolescents and adults with autism. 0. There are a lot with babies, because that's a big area of interest. And I'm not opposed, I'm interested in babies too. But it's a problem. And if you have any potential to write to your senators or your representatives, say, we need more research. I'm going to show you a slide of this in a second. And the problem is when we have research, we have evidence, and we have evidence, we can help people make changes because we can point to the evidence. Let's see. So this will show you, you can sort of see the very hard to see gray columns, the upsurge in research of studies. This is 2008. The black bars at the bottom, which you can see very well, are the intervention studies. Intervention studies are the hardest to get funded. You say, why is that? Intervention studies are like oriental carpets. There's always something wrong. A good oriental carpet, it would be offense to God to have an oriental carpet that was perfect. So it's always, by design, there's a mistake. And this is also true with intervention studies. There's always going to be something, say, oh, they don't like that measure. And it's just the nature of things. And so that's one of the reasons why we don't have more intervention studies. And it is a real problem because we think between Obamacare and the way the insurance companies are pushing, they're going to require evidence-based interventions. They're going to require, show us this works. And that's not that's not a bad thing. It's just that if there's no evidence, that's going to come back to bite us. Because we're going to say there's no evidence, the insurance company is saying no money. And so that's why we need more research, and that's why it's a really critical issue. Okay, this is in some important way the bottom line of my talk we'll come back to. I am cherry picking results here, and I want to tell you why. And the cherry picking is as of this type. These are the first set of outcome studies in autism. Okay? The first studies of outcome, meaning kids followed into adulthood. You follow that? Mm-hmm. And 56 to 74, good outcome means you're independent. Fair means you're semi-independent. And poor means 24/7 residential care. And if you look at these numbers, about 70–75% of kids as adults ended up in residential care. Bad business. Look at this next set, and again, I'm cherry picking, and I'll tell you why. 89 to 2003, the good outcome has increased to about, on average, 30%. And we have good reason to think that number is continuing to increase. It's probably now 40 to 50%, which is fantastic. And it's not just because of changes in diagnostic practice. We think it's because of earlier intervention and better outcome, which is a great news story. On the same page, as it were, sadly, we also have the problem, then how do we deliver services to these kids? And that's a real challenge. And the reason I'm cherry picking these dates, two big things that happened. Between 74 and 89, a big event in this country, Public Law 94-142. For the first time, schools were mandated to provide service. Schools before that time had no mandate to provide service. You could take your child with autism into the school would say, this is a horrible thing, we're very sad for you, take the kid away, we can't possibly provide service. After the federal government said, you've got to provide service, you don't get any federal money, guess what? Schools provided service. Now that's another discussion. And I know it's a long discussion, but it's a big change, philosophically. Same thing happened in some countries, especially England, where parliaments have said the same thing. You got to provide service. And then why do I stop at this point? Because in 2004, and I can tell you because I was in charge of it, we did something called DSM-V that changed the criteria for autism. We purposefully said we want to catch people that are higher functioning that in the past weren't captured by our system, but that still need service. So that's the reason for the cherry picking. But I hope you get a sense of there truly has been a change, and we think it's a continuing change, and it's a change for the better, and it's good news. Treatments. This is a book from 2001 from the National Research Council. The National Research Council, which is part of the National Academy of Sciences, was tasked with the problem of answering the question, do treatments in autism make a difference? And the focus was on preschool children. They had about 10 people, of whom I was one, who we schlepped down to Washington. We had hearings, we had testimony, blah, blah, blah. And then we had a report. And the report said, yes, it makes a big difference. And these are the conclusions. A structured intensive intervention makes a big difference. There are many commonalities and differences between programs. At that point, there were about 10 scientifically based with peer-reviewed studies, programs that were shown to work. And we said, yes, it makes a difference, but not every child gets better, and that is still true. Some kids with the best of programs, for reasons we do not understand, don't make the gains we want. And that's a sad reality, and we need to pay attention to that because they also need services as adults. And we need to think more and seriously about how can we find those kids, how can we better service them. As a group, we have improving outcomes. We know that there are better effects of drug treatments. The drug treatments do not, so far, tackle the core difficulty in autism, which is a social problem. And we have new priorities based on evidence-based treatments. This, in a nutshell, is what the model of treatment is. Autism is a disorder that impacts on development. If you have autism, you miss, I'm not going to show the slides, I don't think, but unless I made a mistake and show them, you miss about 90% of what's going on in the social world. That's a horrible burden to carry. It means you're getting 10%. It's like you have little slits in front of your eyes, and you're catching this little tiny glimpse of the world. So that's the problem. If you lack that social frame, you have horrible troubles. From birth, if you lack that social frame, when you get to the point of going to first grade, you're expected to sit in your seat, pay attention to the teacher, focus on what she or he is talking about. You're going to be in deep trouble already. Deep, deep, deep trouble. On the other hand, what we know about intervention, we want to minimize as much as we can the negative effects that autism has for learning and maximize what we know are the normal developmental processes, which still go on. Kids grow and change, and so we're trying to balance those two. We're trying to push the development, and we're trying to minimize the autism. And that's it in a nutshell in terms of the treatment. Why is outcome improving? We think earlier diagnosis leads to better outcome. Mandates for services lead to better outcome. We have new challenges I'm going to talk a lot about with adolescents who are doing better and then moving on to new opportunities but who need special supports. And the system changes, which we're going to say a lot about in a second. We have changes in terms of legal entitlements, new sets of issues, and mental health issues. Now this, I don't know if we have anybody in the group who's of the more economically, businessly inclined model. But this is actually big money. This is real money. We're talking about taking somebody who has the potential for costing taxpayers $3.2 million, and that was back in whatever this was, 2006, to somebody who's making money and paying taxes. So this is like a night and day difference. This is not a trivial economic problem. And again, if we could try to sell the politicians on this, they hopefully will realize this is not small potatoes. This is a big deal. Similar things in the United Kingdom. Important of functional outcome. The more we can make people functional, the better off both they are, society is, and the economy is. This is, again, not a trivial problem. Increasingly, we have a range of options. We have vocational programs. I was just visiting one tonight. We have transitional programs. We have junior college, traditional college, and the secret good news is that education matters. Any kind of post-secondary education helps. Any kind helps in a major, major way. People with disabilities who get a college degree earn subsequent employment at about the same rate as their typical peers. So this is a big plus. Now that's a 4-year gap. That's a big gap. And we'll talk about that because it's not necessarily an easy thing to get to. But when you can get to it, it's fantastic. It makes a big difference. And here you can see if you don't have college, kind of what you're talking about. And these are the kind of job opportunities. Cashiers are the most, retail salespeople. And of course, keep in mind, these are not necessarily good fits for people in the autism spectrum. Autism spectrum, computers are great fits, solitary great fits, things you can do in isolation, things that don't have a lot of variation, things that don't have novelty, yes. But you can get a sense of there are a lot of jobs out there. But we have a whole surge of people who need access to work, relationships, and independence. But without a college degree, the jobs are mostly in the service sector, which is often a challenge for our kids. Now, it's not an impossible challenge, but it is a bit of a challenge. Employment and disabilities. The unemployment rate for people with disabilities, very broadly defined, is fairly high. It's hard to find a job if you're disabled. It's hard to find a job, even these days, if you're able. About 20% of people with disabilities are working full-time and 10% working part-time. That's not nearly as much as we want. There are no specific data that I'm aware of. I'd be happy if anybody can educate me about this. The last time I checked, which is 2 or 3 months ago, there were no specific data for autism spectrum relative to employment as adults. It does make a big difference if you look at lifetime earnings in terms of what you're going to get. This is overall in the population. We're talking in the range from $500 to $1.5 million in terms of a bachelor's degree, and this is back in 2005. So having some planning, having the vision thing. In general, we want to have a sense of the person. Can they be self-sufficient and independent? Can they hold down a job and have life satisfaction? You have to be realistic. And the realistic part of this is it's not just academic. It's not just the IQ. IQ is misleading. We have kids who are very bright. I had a lady, Kathy Lord, who I'm a good friend of, who's a wonderful person, a great researcher. She presented some follow-up data of kids in her follow-up sample, many of whom are going to college. She said they're cured. You see their IQs, they're great. Then you see their adaptive skills, their ability to meet the real-world jobs. So their IQs are here, their adaptive skills are here. That's trouble. Because you can think through these things, and I'll give you some examples shortly, and then yet you can't function in the world. That's a problem. You really need to be able to function in the real world, and that's a real problem for our folks. So Public Law 94 and 142 established the right to a free and appropriate education for students with a range of disabilities through high school. The thing to keep in mind for college and post-high school, it's a different law. The law changes in its very fundamental way. And the law becomes the Americans with Disabilities Act. College is not a right. There's no right to go to college. There's a right, if you are in college with a disability, to have appropriate supports. That's a fundamental distinction. People can and do get kicked out of colleges all the time for bad behavior. And we'll talk some about that. But again, it's just to keep in mind that the law changes, and this has important implications for the child and family. Colleges, this is the good news, grew out of monasteries. That's actually the good news. Monasteries are very structured. They're routine-oriented. They have food. They have rituals. You show up in a certain place, you will be fed. That's not bad news at all. That's good news. And it's that part of the thing that we like to build on, is this very antique and ancient structure. Food, books, entertainment, and you can pretty much minimize social interaction, although that creates its own challenges. Some colleges are very, there are colleges around the country where you can go online and get a degree almost by not going on campus. Other colleges are extremely social. I mean, Yale, I can tell you, is extremely social. So you're going to have a real challenge if you're there and you have a social disability. So that's the kind of balancing act, and you have to know that there's tremendous variation. High school versus college. This is a big source of confusion for people. Keep it in mind. High school classes, you have 4 to 5 hours a day of structured classes from a teacher. College, a couple of times a week. You're on your own the rest of the time. You've got a lot of potential to screw up. Frequent tests and homework versus occasional exams. High school, the reason they're doing that damn test is to be sure the kid keeps up. College, there'll be maybe a midterm and a final. The class that I do, there's a big final paper. That's it. That's where you get your grade. So you screw up at that, you're in real trouble. And if you haven't been keeping up along, you're especially in real trouble. So again, it's a fundamental difference. Teachers in high school provide the context in terms of expectations, the textbook, they're there, they talk. College is much more expectation of self-learning, doing things on your own. Class size, we're talking 25 versus 300. So we're talking little classes where teachers kind of keep an eye on kids versus large classes where the kid can easily become lost in the great numbers. And one building versus many buildings. This is not to be minimized as a problem. Getting around from point A to point B, it's one thing in one building. When you're talking about a whole campus of buildings and you're talking about a bus and all the rest of it, it's a whole other problem. The kinds of supported programs. There are more and more and more of these out there, and this is great. These range from very minimal, where the college offers some minimal support, to moderate, where students are included, but then they have some very specific services, to very intensive, and there's a number of these programs around the country now that are really helping kids learn about going to college. The focus is not just on getting into college, it's learning how to go to college. So it's like a gap program. For the students, in terms of going to visit and looking at all these programs, and this also happens to the transitional programs, it's really critical to go and visit the program, to get a sense of what it's like in person, to see what the program is, to see what the attitudes are, how sophisticated they are, what's available. You can have wonderful programs that are out in the boonies where there's no resources. On the other hand, you can have big programs, and paradoxically, and you can see this, and you can't predict, you have to know the colleges. Some small liberal arts colleges are fantastic, some major universities are fantastic. The University of Toronto has a wonderful program. They bring the kids in summer. They have an orientation for them. They learn about negotiating the bus. They learn about living on campus. They learn about the whole package of stuff. Some of the Midwestern schools pride themselves on supporting kids with disabilities. The University of Illinois, University of Minnesota, they have whole packages of stuff for people with disabilities. It's wonderful. So again, you have to know, you can't predict just based on size. The kids often are attracted to the most intense, the academically prominent colleges, and sometimes paradoxically, if they do academically very well, they will get in and they'll get there and they'll be a very poor fit because they need a lot of supports. And I cannot tell you the number of kids that talk to me about going to MIT. I actually know MIT extremely well. And, they go to MIT and there's a lot of expectation on MIT's part. You're going to be self-sufficient and independent. You're not going to have a lot of support. So that's the kind of tension you get into. Common problems, the most important problem, the student doesn't ask for help. Under the ADA in college, if the student doesn't ask for help, you're basically screwed. Parents cannot ask for help for the student. There you go. The student has to go. Now, I've had kids, literally, and the kids sadly also flunked out of college, who say, nobody will know I have a disability. And you say, yeah? And they get there and no. I had one kid, he was just immobilized. He knew all about the weather. This was at a small liberal arts college. He knew all about the weather. The superintendent of schools in the high school would call him to see whether they should cancel school. I'm not making this up. He wanted to be a meteorologist. He wanted to be a weather forecaster. And what? He got kicked out of college because he failed physics, I think it was. So what was the problem in physics? There were pop quizzes. They made him very anxious. He couldn't answer the test. Now, with a reasonable accommodation, you could have asked the teacher, let this kid know ahead of time. He will have planned pop quizzes. That's not horribly off the wall. But the kid refused to identify himself. This is the commonest thing. I'm working with a kid up at Dartmouth right now. Same problem. The kid refuses to identify, got into horrible trouble about something, and he refused to explain why he got into this trouble. And it's just, this is the commonest reason kids run into trouble. Nobody will know. And the kids, and you respect their desire for privacy, you respect their desire to make it. That being said, they have a great potential for screwing themselves. College environments, again, lots of things that make it more complicated. There's much more of an expectation for independence and self-sufficiency on the part of everybody. If you identify as needing special help, they will provide it. But if you don't, how will they know? And they won't. So that's the real trick in colleges. And again, colleges of all varieties, small, junior colleges, vocational colleges, vocational programs, you just have to be in there and advocate all the time for the person. What are the academic challenges? There's all kinds of things that cause trouble. English is a problem, essay questions are a problem, group work and labs is a problem, classroom behavior, not interrupting, not making sexual requests, there's a whole package of stuff that you need to work on and that you can work on, but you need to know it ahead of time. Sexuality issues are especially sensitive. I cannot begin to tell you the number of kids I know who are nice kids, they would never ever do anything inappropriate, but they don't know how to ask about having a relationship. And so it comes out extremely awkwardly and it's experienced on the other side, typically by the lady involved, as being sexual harassment. And that gets reported and it's not tolerated. It's really not tolerated, and it's a problem. I'll come back to that in a minute. So you can think about changes you can make in the learning environment. There's a lot of stuff you can do. With textbooks, proofreading programs, note takers, there's a lot of stuff you can pull in if the child is willing to do it. You can also have things like flexibility in terms of tests and the kinds of things on time tests, tutoring and mentoring. All these things can be a tremendous help. Socially, things like life coaching. Somebody who will tell the kid, this is my mantra with kids, you're working with kids who are higher functioning as they get older in adolescence and adulthood. You cannot sit back and wait for the person to tell you how they've screwed their life up. You have to be much more proactive. You have to say, okay, show me how you would make how you would talk to a girl in the supermarket. How would you talk to a girl in the laundromat? How would you talk to a girl in the dorm? How would you talk to her on the lunch line? And I'll be the girl, you be the guy. Let's show me. And homework and rules. I have a relatively young child who has a thing about ladies' breasts. He will come up to a lady on the street and say, you have a nice pair of breasts, ma'am. This is a problem at 6 years. At 16 years, it's a kiss of death. As my Italian colleagues would say, Oscar la morte, it's a kiss of death. Because people are going to see it as sexuality and so he now comes up to ladies. He says, "You have a nice pair of lungs, ma'am." And it's weird. I'm not saying it's not weird, but it's functional. It's not as maladaptive. And so he has a book of rules. He has hundreds of rules. And one of the rules is you do not talk to ladies about their breasts. That's it. Rule number 57. Dr. Volkmar said, on June the 5th, you cannot talk to ladies about their breasts. It's just absolutely forbidden. And again, but this is back to the life coaching model. It's a little different. If I were seeing a Yale College student for psychotherapy, I would be very respectful of my kids. I'm famous in my family. They never ask me for advice. They always ask my wife, because I'll just say, well, what do you want to do? Right? That's a shrink model to the T. Well, but with these kids, no. Total opposite. You got to tell them. And you're there and you got to say, okay, this, you don't do this. And you know what? They appreciate it, because it will make life much more functional for them. Oh, and the other thing, back to the mental health supports, you have to have a plan in advance. So when you visit the colleges or the programs, who's the mental health person? Who will they talk to? Get a signed release from the kid. I can talk to Dr. So-and-so about so-and-so. Otherwise, the parents are out of the loop, because these are adults. And again, it varies a little bit from state to state, but not much. So it's important to keep in mind. Again, there's a whole tension around college versus community versus residential. The beauty of residential, this is the whole point of going to college. Well, you learn about having friends, you learn about having relationships, you learn about being on your own, you learn about going to the laundry, you learn, it's a whole package. It's not just learning about college stuff, it's a whole package. And that's what you lose if you become a commuter student. And that's a temptation, and we'll talk more about that in a second, because it's especially a temptation around going to junior versus regular four-year colleges. And it's not to say one is bad or not bad, it's just a difference. Sexuality issues, again, understanding the rules. There's some good resources. We have a whole section in that book about sexuality issues. There's some really great resources. There are books, there are videos, there's stuff. And about teaching about how you can be appropriate and not get into horrible trouble, which is a big problem. So the 2 or 4 year college problem. The good news, about 90% there's been a 90% increase in the number of kids going to colleges of all kinds, especially in both junior and 4-year colleges. The number of reporting a disability rose from 3 to 19% over the course of about 20 years, which is interesting. And so more and more kids are using this service. About 60% of students with learning disabilities attend community colleges of 2 years or less. And again, I'm not knocking 2-year colleges. They have a tremendously important role. They have some disadvantages too. The problem with 2-year and 4-year colleges, the pros: open enrollment, you can have some experience, you can get some credit. There's many good things about 2-year colleges. You get a track record that you can take it and go on to a 4-year college. The downside is this: you have a kid who's often academically above the other kids in the 2-year college curriculum, academically, socially below. So the kid feels whacked. And the kid feels whacked because they feel like they're out of place, they're above. At the same time, they're below socially. So they get depressed. Depression is the most common mental health problem that we have to cope with in high school and later high school, and especially college students, college-age kids, because they're aware of their social disability, they're aware they're not quite getting it, and they don't quite know how to kind of do it to get there. And so this is a real problem. And the sad news is we have good treatments for depression. Very good treatments for depression, actually. Supported programs, again, not just college. We have a whole range of programs in this country. There are more and more available. We were talking earlier about the kinds of programs. We have a whole number of programs that are out there, and there are more and more all the time. I was saying we have a program in a town that's next to my town, Guilford, Connecticut, Roses for Autism. It's the oldest rose farm in the state. They have a great program of, this is fairly impaired people who are out there working. I work in a group home with 6 adults who are fairly impaired. I think only one is really pretty verbal. One is semi-verbal. One occasionally says something. 3 are totally nonverbal. The people go out every day. They have a full-time job. They have a supporter at the job. They come back home. They work. They clean their dishes. They do cooking. And one night a week, a whole package. They have a summer house up in Vermont. It's a great, for them, it's as quality of life as you're going to get. And again, there's a whole package of resources potentially out there. This varies tremendously from state to state and from town to town. I don't know New York as well as I can know Connecticut. Connecticut, it's just all over the place. Services vary tremendously in schools from town to town, but the adult services also vary. Bizarrely, in our state, along with Connecticut, Mississippi, and Alabama, which tells you really bad news, is theoretically, you can only get adult services if you're mentally retarded. Which means if you got a full-scale IQ above 70, you're out of luck. I don't know about New York State. It varies tremendously from state to state. And we're trying to change that, and we've just got the first time we've gotten a waiver in New Haven County. But again, this is something that you can think in mind. Transitional programs will be very helpful. Stress management of things. There's something called cognitive behavior therapy, which is a very hot thing in mental health. It's a very focused kind of 12 weeks treatment program. There are cognitive behavior therapies that have been adapted for kids on the autism spectrum. There are a number of these now. These are very effective, and they have a teaching aspect, which is good. And so again, just to know there are treatments out there that are effective, and these are effective for anxiety, they're effective for depression. The confidentiality business can get complicated with adults. If you don't have permission from the kid to talk to the parents, you can't talk to the parents. In my state, my wife's a pediatrician, the kid comes in and wants to talk to her about birth control. I think it's at 14 or 15, and I'd be wrong about the age, so don't take it down. But that's it. She cannot talk to the parents. My wife cannot talk to the parents to say your kid's in here asking for birth control. That's, okay, so, and same thing, psychiatric records are even more confidential. So it's an issue, and you have to set this up ahead of time, and you want the parents involved because you don't want somebody getting really depressed and killing themselves without somebody else knowing about it. And this sadly does happen. The mental health problems that we know of, depression and anxiety are the biggies. Mental health services, you want to provide social skills, homework, the whole business. The secret in terms of mental health is explicit. Not subtle, you're explicit. Do not talk to ladies about their breasts. That's it. There's a rule. Let's write that down. And again, it's not the same kind of thing you would do with kids not on the spectrum. But with kids on the spectrum, it's very helpful. Explicit, explicit, explicit. You want to practice adaptive skills. I will have kids practice when they're going to do a job interview. Okay, show me. I'm the guy doing the job interview. Show me why you want this job. Pretend. This is but again, it's practice. And that is very helpful. And finally, the interface with teachers and parents. Having more and more people involved with a vision of helping the child is better. Psychotherapy, broadly defined, can be very helpful. Used in medication, it can be helpful. Having some degree of coordination, working with a network of people, having a village, as Hillary Clinton would say, is really a nice thing. Here's a case example. I want you to guess what this is all about. Take 1 second, go take a guess. Here's the rest of it. It actually goes on for pages. Anybody got an idea?
No. OCD?
The question is, will I ever have a girlfriend?
Oh wow.
So there you go. This shows you the problem. This person who's a math genius, who's got an IQ of 140, who cannot walk into McDonald's and get a cheeseburger and change. So he's got an IQ up here, and his adaptive skills are dreadful. And yet, he's trying to solve this. He really wants a girlfriend. And he's doing it the only way he can, which is through math. And the instant we saw this, we said, oh, this is trouble, because if he realizes the answer is no, guess what? And in fact, he realized eventually the answer was no, and he tried to commit suicide. So that's kind of the trouble. And that's kind of what we're coping with. And so there's a bunch of good resources. I'll come back to this at the end. If anybody is really interested in the college business, this is the best one. It's Wolf, Thurfield Brown, and 1 or 2 other people. But Students with Asperger's Syndrome, a guide for college personnel. It's a fantastic book. It's on Amazon. Jane Brown is the second author. And she's at the UConn Law School in Connecticut. And she's a collaborator of ours and our adjunct faculty. And there are a number of very good resources, but again, just to know, there's stuff out there. There's stuff out there on transitional programs, and there's stuff of all kinds, and again, there are more and more things available all the time, which is great. Now, I want to say a little bit about DSM, which is kind of what got us into this. If you go back to DSM, in the old days, you go back to history, Leo Kanner in 1943 is the person who first talked about autism. And go back to read Wikipedia, you'll read Leo Kanner, it's wonderful. In the 1970s, people realized autism was a brain-based disorder. It was strongly genetic. There was a sort of revision of thinking about how we diagnose autism. By 1980, for the first time, autism was recognized as a category. Up to that time, it was thought to be a variety of schizophrenia, which was crazy. No pun intended. And after 1980, for the first time, it's recognized, and so research starts to increase, which is fantastic. Now, DSM-3 recognized autism as a disorder. There were many things that were positive about it. It was a little overly strict. It didn't have any developmental orientation. This was changed in the revision a few years later. There was a whole package of stuff. And again, by the time we got to DSM-4 and ICD-10, this was back in 1994, and I was in charge of the DSM-4 part. We had a whole history of 10 or 14 years of work. We had a large multinational field trial. ICD is the international system. DSM is the American system. By treaty, the DSM is fundamentally allied with the ICD. ICD regards DSM as a local variant. Now, in psychiatry, DSM has dominated the world. But ICD still regards us as a local variant. As a result of this bizarre treaty, we are allied deeply with ICD. The numbers, the ICD-10 code numbers, are the numbers we use for diagnostic purposes for insurance reimbursement. So there's a very close relationship. For autism, the DSM and ICD-10 definitions we did together because we said, look, this makes no sense. It makes no sense to have an American definition and an international definition. They're different. Let's try to do it together. Michael Rudder from England was in charge of the ICD part. I was in charge of the DSM part. We did a big study, 1,000 cases, 20-some sites around the world, 200 raters over the course of a year, and came up with a definition that's the same in DSM-4 and ICD-10. And I would think you would argue it was reasonably well done for what it was. It was cheap on balance, but it still cost some money. And we had autism. For the first time, we had Asperger's. We had a couple of new categories like Asperger's. We had Rett's, something called childhood disintegrative disorder, which are very rare degenerative conditions. And then we have PDD-NOS, which is the catch-all category for kids who don't quite fit in. And it's basically the same in DSM and ICD. And as a result, we think research increased dramatically because it's the same thing around the world. So DSM-5, well, this is a problem. So this is the DSM-4 system. We've got basically 4 well-defined categories and this much larger, much more poorly defined category, which we know because it's by definition subthreshold. It's close but no cigar autism. It's going to be, well, not quite, but needs more or less the same program. And again, I emphasize, the kids have not read the book. The kids do not know, I need to beat boom, 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 boom. The kids are who they are, and we need to provide services for them no matter what. So that's intrinsically a tension with the system. And things like Asperger's is a very interesting disorder because the social troubles are marked, they're very similar to autism, and the but is these are kids who are quite verbal, they often have unusual interests, these are things that get them into trouble. Before DSM-4, and DSM-3 and 3R, these are kids who would have been lost to the system because they were very verbal. People say, oh, they're smart kids, forget it, they don't have troubles. They actually have major troubles that can actually be addressed. And it's an interesting condition, and I would argue it's actually quite interesting because it has many differences from autism, and this sort of summarizes some of the differences. Kids with Asperger's have motor troubles. Kids with autism early in life don't have motor troubles. Often they're very good motorically. They're very good artists. They can pick locks. They can do other kinds of things. Kids with Asperger's are very motorically disabled. They have horrible troubles. The social thing is the thing that's in common. Asperger's, if anything, also seems to have a more positive family history, where the kids, it turns out the troubles tend to run in the families even more so than in autism. And PDD-NOS, again, it's a very complicated problem, but they're probably with many subtypes embedded within it. As the genetics have gone on, we've come to appreciate there probably are many kinds of autism. There are many autisms, and there are probably many variations, of which some varieties are more in this PDD-NOS category, where the social deficits aren't as severe, but the person still needs some services and some help. So DSM-V is supposed to come out in May. It has major changes both in terms of its organization and structure. There's a new name, autism spectrum. Now, you would think autism spectrum means big tent. Paradoxically, that turns out not to be true. It's clear it's not true. The question is how much it's not true. And so that's the interesting thing. And one of the things I object to is because it seems to be a bigger tent and in fact isn't, I sort of feel like people are misled. And I think that's unfortunate. There are no atypical categories. There's no NOS anymore in DSM. Now, I also think that's probably a very fundamental mistake. And the trouble is, ICD, there's two books. There's a research book and there's a clinical book. The research book, there's diagnostic guidelines. The clinical book, there's just a description. And that's because the ICD people say, you know what? Research and clinical, different. DSM has never ever done that. DSM has always been the two things are the same. That's a tension, and there it is. There's a new category of social communication disorder. At first you would think this is going to be PD&OS in disguise. They say it's not, although we still don't know. And that's sadly one of the problems is we still don't know even today what the impact of this is going to be. And also, unfortunately, this is a bit of a moving target. Things change all the time, and we don't know what the changes are. It's disappeared at the moment into the bowels, as it were, of the DSM work group. We have no idea what's going to come out in May. Could be the same, could be different, probably will be the same. Autism spectrum, again, one might think it's a broad concept. In fact, it's somewhat narrower. Why is it more stringent? If you look at the way autism is defined in DSM-IV, there's three baskets. There's a social basket, there's a communication basket, and there's an odd behavior basket. And there's 4 items in each basket. So you think of red balls, yellow balls, and blue balls. There's 4, 4, and 4. You have to have a total of 6, and 2 of those have to be social. If you start doing, if you're a mathematician, you can figure this out. The minimum is 6, and you have to have 2 social. There's well over, I think it's 2,500 combinations of criteria that will get you there. The new system, they lump social communication together, and again, you can argue the merits of this. They have 4 other behaviors. All of a sudden, you're going to A and B, A and C, A and D. You can count them on the fingers of one hand. It's not nearly as many. It's markedly less than we had before in terms of ways to get in. Now again, you can say, well, maybe it's not true, but that's, I mean, if you just do the math, that's the reality, is it's much more restrictive. Now again, we'll have to see how it works out in real life. The sensory issues, in fact, also was added essentially as, I think, as a kind of a SOP, because there's not good data when we looked at DSM-IV. Sensory issues didn't work very well. Sensory issues were kind of non-specific to kids with disabilities. They didn't differentiate kids with autism. And again, the trouble with throwing this in is that sensory problems are a little more common in the more disabled kids. I'm not knocking the disabled kids, they have their needs too. But what that means is if you throw that as a criteria, you're biasing a bit against the more able kids, if you follow that. So what happens to the cases? Well, again, if you only look at the more cognitively able, and if you look at the ones, and we did this and we published this paper which got some press in the New York Times, if you look at the DSM-IV, the data we had from DSM-IV, and you try to make it fit, the bottom line, autism, about 72% of the cases met the criteria for the new thing, which means 20, whatever it is, 28% didn't. Asperger's, 24% did, which means 76% didn't. And PD&OS, 16% did, which means 84%. So these are big numbers. And again, the problem is we don't know what numbers are really accurate here. And if you look at our paper, bottom line is about 40-some% of the more cognitively able kids with IQs in the normal range lost a diagnosis. Now the trouble is we really truly don't know what's happening. The DSM-V group, they just published a very large study. It was cases, extremely well characterized. They had the 2 sort of gold standard diagnostic instruments, the ADOS and the ADI. You had both instruments, it did pretty well. You took one instrument away, it went down significantly. The trouble with the instruments, which is what this is all based on, And again, you can argue this is rational because it's good science, and indeed the instruments are wonderful. I'm not knocking the instruments at all. The problem is it's not real world. Doctors out in Pocatello, Idaho, they're not going to go through a week of ADOS training or a week of ADI training, which is what it takes to be able to use the instrument. And there's no data to show how this works in the real world. So I think the question now is not the kids are going to lose a diagnosis. The kids are. The question is how many. And it's somewhere between 10 and 40% probably. And we don't know. And the reality is, and if you read the New York Times as avidly as I do, and Science Times this week, they said, well, kids won't, they can keep their diagnosis. That's great. The trouble is, my other hat is the journal editor. What do you mean they keep their diagnosis? You change the criteria, you should change the diagnoses. And if I were a school administrator, I'd say, well, let's take a look at the kid. Does the kid meet the current diagnosis? Does the kid meet the current criteria? And if not, do we need to provide services? Especially if I were a school administrator concerned with the amount of money I'm hemorrhaging out of special ed. So that's the tension. And again, it's truly we don't know. There was an editorial in the American Journal of Psychiatry with this paper from the work group looking at this large data set, basically saying we have no idea what the impact is. And I think that's, sadly, is the real problem with this. And again, all the studies that have used the non-sort of mega data sets with the ADOS and the ADI have reported these problems. And it's not just 1 or 2 studies, it's now like 5 or 6 or 7 or 8. So it's pretty clear there's an issue, and the question is we still really don't know what the issue is. So the future, we have papers on both sides of the issue. There's some things about the new system that are great. Changing the label to autism spectrum disorder makes good sense. Having things where you can talk about dimensions of severity, that makes good sense. There's some things that are positive, some things that frankly are perfectly crazy. And I wish I could say that I thought this was a happy thing. I think it's not. I think it's a train wreck. And I may be wrong. I hope I'm wrong, because I hope it doesn't impact on kids in a negative way, but we'll see. And the sad news is, in the worst case, if I'm wrong and it is a train wreck, they'll come out with a DSM-5R or a DSM-6. So I just want to say a little bit about the kinds of things we're trying to do in terms of Yale-related things. We have a new set of programs. We had a program I was mentioning to a couple people last April. We had about 250 people, 75 high school kids. The rest were parents and teachers coming to hear us Sunday, so people could come, no matter what their religion was, about going to college. We had Jane Brown who talked. We had the director of Yale College Admissions who talked. We had some generic talks. We took the kids off in the afternoon apart from the parents and teachers. We had kids having meltdowns, crises, all kinds of stuff. It was amazing. But really to sort of, and teaching them about things like how do you cope with anxiety? How do you cope with other stuff? And really trying to give them some education about this. And we hope we'll be able to do the same thing. These are things you never make money at, so the question is how much money can we afford to lose? But we're going to try to do that again this spring. We're trying to also offer some new programs, consulting programs basically to parents and small groups of kids. We're thinking about a model where 4 or 5 parents and the kid would come to us. We would have a kind of a general orientation session, and then we'd have 2 or 3 or 4 hours, many hours of different things like a review of the psych assessment, a review of the mental health problems, discussion about the college programs, and discussion about recommendations for specific colleges that we're trying to pull together. We'll see if we can bring this off. We're also trying to develop some new services for adolescents and adults in terms of psycho skills, social skills, and also psychopharmacology and CBT. And lastly, I'll end with my little doggie, who I just took a picture of, and I was saying, I had this horrible experience. I spent the weekend with my wife in the dog ER because our dog, we had visitors from Russia, and we happened to notice our dog was bleeding out of his gum. This is the loveliest dog we've ever had. We've had nice dogs over the years. And so we took this dog to the vet, and the next thing you know, we're in the ER, and they're saying he's got cancer, he's going to die.
Oh my God.
So you can imagine, my wife and I were crying, it's a mess. And then, of course, he's got a bone marrow, we take him home, we're going to hope to support him, and blah, blah, blah. And they call and say, you know what? The bone marrow is fine. So the dog is fine. He's got a tick illness. So anyway, that's Pete. That's the happy story. There's Pete. So I'll stop with Pete. And if you want, there's more information. And we're always interested in getting feedback. And again, if you want to be on our mailing list, we have a mailing list. If you want to hear about conferences and other kinds of things, let us know, because we're really interested in trying to do more in terms of outreach. And New Haven, amazingly, is not hard to get to. You can take Metro North, get off, and take the shuttle bus, and it's 2 blocks away from the train station, and you're there. So thank you very much. I'll take some questions.